Welcome one and all to the third episode of our Rising Stars in Ophthalmology Season 2. Well, today we touch upon a topic that is very close and dear to me, the latest advances in refractive surgery. And we have a plethora of experts to talk to us about it today. But before we go ahead and introduce them, I would want to tell you a little bit about the Rising Stars series. Well, it's a 9 virtual episode series which actually happens online only. Each episode will feature one rising star and we surround them with 3 celebrity panelists. By celebrities, I don't mean the paparazzi followed celebrities. Sorry to disappoint folks. I mean the real heroes in the field of ophthalmology who we all learn from and we all cherish and expert as our mentors. This is an interactive series, so please keep the discussions going. Any audience member watching from anywhere can throw in their questions into the chat window on our website or on our YouTube. And we as moderators will put forth those questions at the right time to the celebrity panelists and the speaker. We're live on risingistars.com and also can be viewed on our YouTube channel, Rising Stars in Ophthalmology. The reruns, obviously, because this is a global event, can be watched on our website only. And also watch out for our social media, Facebook, Twitter, LinkedIn, Instagram, etc. Also, especially for our educational tips and snippets on each of the episodes, because we take the pearls out and actually project them there. I want to thank each of you for tuning in, and thank you sponsors for making this happen. Yeah, it's really an honor to be here. More importantly, I want to now hand over to Jen to kind of introduce our speakers, celebrity panels, and also our sponsor talk for the day. Jen, all yours.
Thank you so much, Ashwin. It's a pleasure and honor to again be co-moderating with you. I'd first like to start off the night by thanking our sponsors for this season, which, as you can see here, Allergan, Alcon, Visus, Avellino, Dompe, Sun, and Tarsus. And I'd like to specifically acknowledge Avellino tonight as our guest sponsor for the evening. And they will be represented by Dr. Sam Garg tonight, who will be saying a few words before we begin our show.
Sam, you're on mute.
Here you go. Can you hear me now? Okay, great. Thank you, Jen, and thank you, Ashwin, for organizing this. And on behalf of Avellino, I'll be talking about the Avogen genetic eye test. So how does genetics help us with respect to our current diagnostics for our refractive surgery patients, which Nandini will be touching on later today, and also our patients that we look at who have keratoconus. And oftentimes we have a clear diagnosis, but in some patients, we don't really know for sure whether or not we're dealing with something like keratoconus or if there's a corneal dystrophy. And we think that this genetics can help us with this. And so we have our diagnostic tests, our ocular measurements. We know there's environmental risk factors, and Avogen may be that missing link to help us choose the correct treatments for these patients where there may be some quandary in their decision making. So what is the Avogen test? Well, it's a test that's easily administered in clinic. It tests for 75 keratoconus-related genes and up to 2,000 plus gene variants. It can also test for the TGF-beta1 gene and the various variants of that gene. And with this, it can either give you a keratoconus risk score, or it can tell you yes or no whether or not they have this TGF-beta1 related corneal dystrophy. So when do you order this test, or when do you consider ordering this test? Well, in our practice, we're going to start implementing this for patients with a positive family history of keratoconus to know if perhaps a sibling or a child has keratoconus. Certainly if there's irregular topography and we're wondering about the impact for refractive surgery, and if this is a good patient for refractive surgery. If there's a quandary where we're not sure if this patient may be a good candidate for refractive surgery, I envision the Avogen test being that tiebreaker that we need. Coupled with this, the company has provided genetic counseling to patients and doctors so they can go over the results and really understand what this means for them and their family. So here's an example of a patient from Dr. Elizabeth Yu. This is a 32-year-old patient presenting for refractive surgery evaluation. Her glasses are a couple of years old. You can see that she has quite a bit of astigmatism with the rule. Current manifest refraction shows a little bit of myopic progression and a change in her astigmatism on her right eye. And so she was wondering if she's a good candidate for perhaps a refractive surgery evaluation. And looking at this, looking at her maps, you can see here she has fairly regular astigmatism on the right eye and on the left eye as well, but a high amount. And given her age and given the pattern, you may be concerned for something like keratoconus. So the Avogen test was done. It showed a very low risk for keratoconus, and Dr. Liu proceeded with LASIK or PRK, and this test really helped make her more confident in her decision for this patient. So thank you very much for your attention, and I'll give it back to the team here.
Thank you so much, Dr. Garg. And now I would like to share my screen and introduce our amazing team here for episode 3. So first up, we are honored to have Dr. Eduardo Alfonso, who is currently the chairman of ophthalmology at Bascom Palmer. He is with us tonight and to give us his expert advice. He originally went to Yale College and then did medical school at Yale as well. His residency was at Bascom Palmer, and he did 2 fellowships at Harvard, including cornea and ophthalmic pathology. We're also very lucky tonight to have Dr. Sam Garg, who is the vice chair of clinical ophthalmology at the Gavin Herbert Eye Institute, University of California. He did college at USC, New York Medical School, residency at Indiana University in medicine, ophthalmology residency at University of California, Irvine, and a cornea fellowship also at Irvine. And last but not least, we were very fortunate to have Dr. Bill Wiley here with us tonight. Dr. Bill Wiley is a medical director of the Cleveland Eye Clinic. In college, he went to University of Virginia, medical school at the Medical College of Ohio, and residency at Rush. He also did some interesting additional training in Moscow, where he did a clinical clerkship with Dr. Fyodorov as a pioneer in radial keratometry. So welcome and thank you for your time to all of our celebrity panelists. I'd like to also introduce, many of you already know her, and she's our rising star tonight, Dr. Nandini Venkateswaran. She's a clinical instructor of ophthalmology at Harvard Medical School, and she's also the cataract, cornea, and refractive surgeon at Massachusetts Eye, Ear, and Infirmary. She did college at University of Rochester, as well as medical school at Rochester. She did a residency at Bascom Palmer and a cornea fellowship at Duke University. And currently she is in Boston. She's showcased some very cool pictures here, and I usually like to give our rising star a few moments to explain and describe these photos and what you're doing.
Sure. Thank you so much, Jen. These are just some fun pictures I was asked to share. As you mentioned, I did my cornea fellowship at Duke University, and I had such awesome mentors. The picture in the middle is with Terry Kim, Missy Dallavoy, and Lloyd Williams, all of who really formed me into a cornea and refractive surgeon. And I wore my Duke shirt around Boston for the first 2 weeks I was here, and took a funny picture in front of Harvard Medical School just to rep my 2 affiliations. And you guys asked for some action shots, and pre-COVID, I love to travel. And this is when I went to Costa Rica and decided to zip line for the first time in a forest in Costa Rica, and proceeded to get stuck on the zip line and had the instructor save me. So just like I have my attendings to save me in surgery, I needed someone to save me as I was ziplining. So I thought that was a pretty fun picture to share. We can go to the next slide.
Up, sorry. Yeah.
This is just a picture of my extended family. I had my parents and many of my aunts and uncles and cousins came to actually celebrate my medical school graduation in Rochester. And I'm just so thankful for such a strong clan to all show up and always cheerlead me on, through every stage of my training. So just wanted to share that picture.
There you go.
And then lastly, just some fun pictures from Miami. Jen and Bill were good friends. This is us at dinner at Barton G just a few weeks before I left Miami after my residency at Bascom Palmer. And Dr. Alfonso was my chairman there. This is a picture of my whole residency class and him on a boat cruise that we do every year in Miami, which is fun, and a cute selfie of us before I graduated. So very thankful to all the organizers and to my esteemed panelists for sharing their night tonight to discuss refractive surgery.
Thank you very much. All right, I'll let you take it away.
Awesome. All right, can everyone see my screen?
Yes, everything is
All right. Great. Well, I just wanted to extend a big thank you to the organizers of Rising Stars in Ophthalmology. I've been tuning in since episode 1 and have found it to be such a fantastic platform to learn. And I'm really honored to be able to share one of my favorite topics in my practice, which is refractive surgery, and pick the brains of my esteemed panelists, Dr. Wiley, Dr. Garg, and Dr. Alfonso, and their thoughts and pearls that they have to share for some of our refractive surgery patients. Of note, these are my financial disclosures. I am a consultant for Alcon, whose content I'll be discussing on my slides today. And I just wanted to extend a thank you to some reps from Zeiss, Alcon, as well as Dr. Christian Song from Massainier for help with some slides in this talk. So just to get the discussion started, as I was thinking about how far we've come in laser vision correction, refractive surgery, it's really fantastic at how the technology has grown over time. We first saw the FDA approval of PRK in 1995 and the subsequent approval of LASIK in 1998. And LASIK at that time was being performed with the microkeratome to create our LASIK flaps until the advent of the femtosecond laser in 2001. And now we have several different femtosecond laser platforms that can be used to create pristine LASIK flaps for our LASIK patients. And several years later, we've seen the FDA approval now of SMILE, or small incision lenticule extraction, which has allowed us to add an additional technology to our refractive armamentarium for our refractive surgery patients. So as a comprehensive refractive surgeon in 2021, there are so many different techniques that we can offer and implement for our patients. I think many of us are performing PRK and LASIK. These are tried and true procedures that have really been the first ones that we've used for our patients and the longest that we've seen in terms of visual outcomes. But now we have the introduction of additional technologies like topography-guided ablations, small incision lenticule extraction, and even implantable Collamer lens technology. And the question becomes, what is the best option for our patients? And so in my practice over the last year, I've had the opportunity to implement 2 new technologies into my practice, topography-guided treatments, as well as small incision lenticule extraction. And I hope that we can, over the course of the next 30 minutes, discuss some cases of patients I saw in my own clinic and look to see when we would implement these different technologies and who our best candidates are for these different procedures. So we'll start off with our first case. This was a 36-year-old female. She presented to me for laser vision correction. And on her refraction, you can see that she's a low myope with some astigmatism. She had a very normal anterior and posterior segment examination. I always do epithelial thickness mapping for my patients and found that she had very normal epithelial thickness maps. And on tomography, she had normal pachymetric maps, slightly thinner than average, but on average 516 in the right eye microns and 512 in the left. And on her Bell and Ambrosia enhanced display, which helps me understand her risk factors for ectasia, she had a normal D score in both eyes. One scan that I love obtaining for all my laser vision correction patients is the OPD3 scan. And this is a machine that helps me obtain a plethora of information in just one snapshot. It's a built-in topographer, wavefront aberrometer, autorefractor, and pupillometer. And it helps me understand what the status of the patient's eye is. So you can see here in my patient's eyes, she has symmetric bow tie with the rule astigmatism. But what stood out to me was actually the higher degree of corneal aberrations present in her cornea, in her right eye, her total coma, trefoil, as well as higher order aberrations, as compared to her left eye, which had some, but to a smaller degree. So with all of this information, Dr. Alfonso, I have a 36-year-old female. She's a low myope with some astigmatism and some higher order aberrations. What would be your preferred laser vision correction approach for this patient?
Well, Nandini, as you know, I don't practice refractive surgery, but I do see a lot of patients that are dissatisfied with refractive surgery because that's the nature of my position at Bascom Palmer. And I would say that certainly a highly motivated patient like this probably LASIK. But I would also question in a patient that a female that's 36 years old, what would be your endpoint refraction that you'd like to leave this patient so we don't push her into presbyopia perhaps too soon. So I would venture to do the surgery that I could potentially come back and do some tuning up so that I can help her at least to consider monovision and keep one of her eyes for distance and one for near. So probably LASIK, probably discuss with her monovision, and probably also make sure of knowing what her aspirations are in terms of her visual function.
Those are great points. And all of those discussion points I had with our patient. She is a very active mom, has 2 toddlers, and was really motivated to have good distance vision and knew that presbyopia was in her future over the next 10 years, but aimed to have distance correction in both eyes. And we discussed the 2 major options that I thought were applicable for her, which were PRK or LASIK. And she chose to have LASIK, but we decided to actually pursue topography guided LASIK for her. And I'd like to discuss, why we chose that and how we came up to that decision. So to start that conversation, I'd like to kind of go over the differences between what are more common treatments, which are wavefront optimized and wavefront guided treatments, and compare it to topography guided treatments. So wavefront optimized treatments are typically going to be treatments that are going to treat the manifest refraction, and they don't address any higher order aberrations. But our wavefront optimized treatments have really evolved to help us maintain the total asphericity of the cornea and not induce any additional higher order aberrations when we treat our patients. In contrast, wavefront guided treatments are going to be customized corneal ablations that not only treat the patient's spherocylindrical correction, but will also be treating the higher order aberrations present that are measured based on ocular wavefront aberrometry. And our wavefront aberrometers are going to be able to address all aspects of the patient's optical system, starting from the tear film to the lens to the retina and vitreous, measure the patient's higher order aberrations and help us translate that into a corneal ablation pattern. So how do those differ from topography guided treatments? Well, topography guided treatments are going to aim to reshape the corneal surface into an ideal curve while also taking into account the patient's spherocylindrical correction. So it's going to design a personalized treatment for all the corneal abnormalities that are present on a patient's cornea based on corneal topography measurements. And corneal topography measurements can help us capture the irregularities, especially in the peripheral cornea, which can contribute highly to higher order aberrations. And the treatments themselves help us address sphere, CIL, as well as higher order aberrations simultaneously. And these treatments are going to be centered on the patient's corneal vertex. Initially, topography-guided treatments were actually developed to help be a corrective tool for highly irregular corneas. So corneas that had previous laser vision correction with decentered ablations or required enhancements, or even keratoconic or ectatic corneas, or corneas with scars. However, when this technology was brought into the United States, the FDA actually asked us to study it on virgin corneas. And we found that it was actually a very successful procedure in our virgin patients. So the actual FDA approval for this treatment here in the US is that of myopic astigmatism, treating up to -8 diopters of sphere, -3 diopters of CIL, and up to a total of a -9 diopter spherical equivalent. But many surgeons are still performing off-label treatments for our highly irregular corneas. Of note, we're not able to perform hyperopic treatments with our topography-guided ablations, but globally we can. As I was alluding to, our FDA studies found that topography-guided treatments allowed our patients to achieve excellent visual acuity with follow-up of up to 1 year. And the majority of the patients actually did not have any visual phenomenon, such as glare and halos, starbursts, or difficulty driving at night, which are often concerns after any reshaping procedures on the corneal surface. So Dr. Wiley, in your refractive practice, who do you find is oftentimes your ideal topography-guided treatment candidate, as opposed to wavefront optimized or wavefront guided treatments?
Yeah, in general, I'm looking for somebody that has true irregularity, so higher, RMS, error. I think if it's a normal cornea, there's a chance that topography guided LASIK may actually sort of introduce a variable that's a little harder to predict than just sort of wavefront optimized. So I find that I tend to get better, uncorrected vision with wavefront optimized in most eyes. But if there's some abnormality that's present, I think it is worth it to try to do the topography guided and maybe increase fast corrected visual acuity. So there's always a chance when you introduce that variable, you may correct the abnormality, but then introduce a sphere error and maybe overcorrect or undercorrect. And so you've got to kind of weigh those two things. So I think it is sort of an individualized consideration and not necessarily a one size fits all.
I have a quick question, Nandini. Was this patient refracted to 20? Would they refract to 2020? I might have missed that.
Yes, they refracted.
Initially, she did.
Yes.
Okay. And did she notice any difference in quality of vision between the two eyes?
She didn't actually. She didn't specify any specific glare or halo or more aberration in one eye, which I asked. I was curious, but she didn't state anything.
Right. And so I think sometimes, we have to be careful to make sure that we're treating the patient and not the test. And often make sure we verify that the test is actually correct. So I probably would have, not having access to topo guided LASIK, which I think is amazing. I probably would have lubricated and rechecked and to see if it's still there, because sometimes these things go away with repeat testing. Just a thought.
Oh, absolutely. It actually, when I saw it initially, I didn't believe it. So I had her come back in a week and I repeated it. I forgot to mention that. And it was interesting. It persisted. And like Dr. Wiley was mentioning, I think oftentimes when I'm trying to identify patients for topography guided treatments, I'm spending quite a bit of time on the planning station, actually looking to see how much of higher order aberrations they do have in their cornea when you remove their spherocylindrical correction. And there are many planning softwares that we're able to utilize, and different surgeons have different preferences, which help us see whether or not the patient is indeed a good candidate for topography guided, or if it's better to default to wavefront optimized treatments, for fear of inducing further aberrations like we were discussing. But those are excellent points.
And I agree with, looking at the planning station. I think that is important. And typically I want to see how does that plan, compare to what the, let's say the elevation pattern is on the topography. So I think I like to look at the elevation pattern and see if there's a little bit of a hot spot or a little bit of a irregular astigmatism, and see, does the, plan match with that? And if it makes sense, then I feel like I'm making an improvement. But let's say if it's just like Dr. Garg was saying, maybe it's an artifact on that one single measurement, you don't want to, treat that permanently. So you want to look at the maps, look at the plan, make sure that they sort of, logically make sense if you have that ability.
Absolutely. And I think, even doing simple things like epithelial thickness mapping have helped me find artifacts. Many of our refractive surgery patients have ocular surface disease. So you'll get irregularities on epimaps or even topography, tomography. So lubricating, bringing them back. And like you said, making sure that all of those pieces fit together will help us identify whether or not our data is true or is incorrect. So our patient did very, very well. I did topography guided LASIK in her right eye. And this is actually a map of what that planning station treatment pattern looked like for her. And at 3 months post-op, she was 20/15 in that right eye, very happy. And we could see a reduction in those higher order aberrations that we were initially measuring on the OPD3, along with an improvement in her refractive error. And similarly in her left eye, she did very well, 20/15 vision in that eye, with an overall stability in the higher order aberrations and excellent refractive outcomes as well. So I think, topography guided treatments can be a tool in our toolbox when we're identifying the correct patient who could benefit from those topography guided ablations. So I'd like to switch over to my second case. This is a 25-year-old male who's presenting for laser vision correction. And in contrast to my first patient who was a low myope, he's certainly a very high myope with some astigmatism. He had a normal anterior and posterior segment examination, normal epithelial thickness mapping, and very thick corneas on his pachymetric maps that appeared healthy. And also on his Bell and Ambrosia enhanced display score had normal D values in both eyes. His OPD scan overall suggested very normal appearing corneas, low degrees of higher order aberrations, and a consistent refractive error. So Dr. Garg, for a 25-year-old male who's a high myope, what would be your preferred laser vision correction approach, and how would you come to that decision?
Yeah, so this one can be complex because it depends on sort of what they're looking for, what their risk tolerance is, how quickly they want their vision to recover, what you have available to you or what's in your neighborhood. You could really choose any of them. I mean, if you go PRK because he's really active, you have to worry about haze and maybe using mitomycin C. I'd probably feel comfortable doing LASIK on this with a thicker cornea, depending on how thick your flap was. You have to talk to them about maybe not having that much tissue left over for an enhancement if they need it. Certainly SMILE, this seems like a very good patient for SMILE, given the fact that there's low amounts of astigmatism and it's myopic. You could even consider an ICL in this patient if they're so inclined. And so, really this is a patient where you could do any or all of them, and you sort of have to go through the pros and cons of each technology with the patient, sort of like you do with the most common refractive surgery, which is cataract surgery, and the different lenses we have, and what the pros and the cons are for each lens with the patient, and letting that I'm a big fan of letting the patient be part of that decision making, so they understand sort of the complexity, and let them help themselves make that decision, is obviously with giving them guidance.
100% agree. And I actually present this is a boy who would actually benefit from all procedures, like you mentioned. So I offered him PRK, LASIK, and SMILE, and we went through the pros and cons of each of them. And he was actually very interested in SMILE as a result of the fact that he didn't need to have the LASIK flap, and he was excited that it was a new and upcoming procedure. So we decided to pursue it, and we'll kind of go through what SMILE is and how we came to that decision. So SMILE stands for small incision lenticule extraction, and it's a procedure whose inception was in 2011, and in the United States, it was FDA approved in 2016, and we've really seen it gain rapid momentum over the last several years, with more than 4.5 million procedures being performed worldwide. And notably, SMILE is performed by one femtosecond laser, and that's the Carl Zeiss Meditech Visumax femtosecond laser. And the procedure aims to create an intrastromal lenticule that's designed based upon the patient's refractive error in order to correct their refraction. And so the laser is going to be creating 4 specific cuts to help us generate that intrastromal lenticule. You can see those delineated in the diagram here. The first is the posterior cut, which is going to be the refractive cut. It's going to define the refractive power of that patient's lenticule. The second is the lenticular side cut, which is going to determine the diameter of the lenticule. The third is the anterior cut, which is going to delineate the anterior surface of the lenticule and is known as the cap cut. And then lastly, you have the opening incision, and this incision is going to allow you to gain access to the lenticule as well as remove it after your manual dissection. The Visumax laser uses a unique curved glass contact interface that's going to obtain corneolimbal suction as compared to other femto platforms that obtain bulbar conjunctival and scleral suction. So it's often a very soft and comfortable dock for the patient. And when the SMILE treatment is being performed, it's actually being performed under suction. So it's very important for the surgeon to center the treatment on the patient's visual axis. So I often have a printout, like you see here on the bottom right, of the patient's eye from my OPD scan that helps me know where the patient's visual axis is so that I can center it appropriately. In the United States, SMILE is approved for myopia, ranging from -1 to -10 diopters, and also for astigmatism, ranging from -0.75 to -3 diopters, with the maximum spherical equivalent treatment ability of up to -10. And both in the United States and globally, SMILE is not yet approved for hyperopic treatments and is still investigational in nature. So Dr. Wiley, I know that you perform quite a bit of SMILE in your refractive practice. Can you share with us who you feel are your ideal candidates for SMILE and how you first incorporated this technology into your practice?
Sure. I think right now we're probably pushing 70% or so of our patients are having SMILE that are having corneal refractive surgery. So more or less anybody that meets the criteria for the prescription, we like to offer SMILE. We just see some advantages with things like dry eye, low enhancement rates, patient comfort, healing time, those sort of things have, tend to sort of be an advantage, with everything else being relatively equal. With that said, we still do a lot of LASIK, but I think that there's just a slight nod towards SMILE that we found that we prefer. But I will say it's taken some time for us to get to where we are. We first started with SMILE back in 2016, and at that point, the laser energies weren't quite optimized. We were a little bit boxed out from what we could do or what we could adjust with the laser, so the results weren't quite as tight. Also, some of the at that point we could not treat astigmatism. We weren't that comfortable treating lower prescriptions with smaller or thinner lenticles. So it took some a time for us to sort of become comfortable with a wide range of treatment. We also think there probably is a learning curve, and it took us some time to work through that surgically. So it's been a process of the first few years where maybe 5% SMILE, and now it's like I said, we're almost everybody that fits within the parameters. We tend to lean towards SMILE.
That's great. And my colleagues here at Mass Eye and Ear who are performing SMILE have also, really morphed the majority of their refractive surgery practice into SMILE. Do you often co-consent your patients for SMILE and LASIK?
Yeah, great point. I think, I tend to tell patients that, all the procedures are great. We actually, consent for SMILE, PRK, and LASIK, just in case we need to, change gears. And I discussed that sometimes there's something with the anatomy that we can't predict. And maybe we'll lose suction, or we won't get the doc that we're looking for. Maybe we're not comfortable with the centration, something along those lines. And so it's a much easier discussion to have had that done, before surgery than in the middle of surgery. So we do consent for all three procedures, and let the patient know that, we have a preference to go one direction, but they're all great. And, thankfully there are options, and in general, most people do well, no matter which path they go down.
Yeah, I completely agree. I often co-consent my patients, and I let them know, that the first 15 seconds of the SMILE treatment is so critical to obtain that refractive cut. And if there's any point that we lose suction, it's always okay to, revert to plan B, and that's going to be a better and more safe procedure for the patient. And I think oftentimes patients like to know all of their options. I find that my SMILE patients, many patients at Mass Eye and Ear come in asking for SMILE because they actually know that we're one of the locations that has the VisiMax laser. And that has been a really nice way for me to build my practice. So I actually started incorporating SMILE because I was seeing a need for it in the patients that were presenting to me.
That's great.
Those were great points. And I think you actually alluded to a lot of the reasons that many refractive surgeons I speak with opt to incorporate SMILE into their practice, because it offers an opportunity to do a flapless refractive surgery procedure through a small incision. And so you don't have those flap-related complications potentially that LASIK could offer to the patients. I think our FDA studies have shown that SMILE can offer excellent visual outcomes for our patients with good refractive stability over long-term follow-up. And the fact that it's an intrastromal lenticule without a flap allows us to preserve more corneal nerves and potentially more of our anterior stromal lamellae, which leads to less dry eye and more biomechanical stability for our patients. And as I was alluding to, it's really been an opportunity for us to really build our refractive practice and offer a competitive alternative that other surgeons may not be able to. And we see a demand for it in patients who've done their research and come in requesting a particular procedure. But I think with any new technology, there are some growing pains. As you were mentioning, I think there is a steeper learning curve. It is a different procedure from LASIK and PRK technically as you're performing it. And as the energy settings were being optimized over the years, I think there was a slower visual recovery with higher energy, and even in patients with lower prescriptions as compared to the higher prescriptions. But we've seen an expansion with that throughout the years since 2018 as the ranges for the FDA were expanded. From a practice standpoint, I think the surgeon also needs to be willing to invest in a new laser. You specifically do need the VisiMax femtosecond laser to perform SMILE, and you still do need to have access or actually have an excimer laser in your office to be able to offer LASIK or PRK, or even offer an opportunity for enhancements. And though there are very few reports in the literature suggesting ectasia, I think there is potentially still a risk for ectasia, even with SMILE, in addition to that same risk that's posed with LASIK or PRK. I think for my first 20 to 30 eyes that I've performed with Smile, I have really seen a huge growth in myself. And these are some tips that I've picked up for any of the young surgeons who are looking to incorporate Smile. In that, I think it's very important to rely on your industry representatives as well as your colleagues who have been performing this for quite some time. They have tips and tricks as to how to better improve your technique and become proficient, especially with different ranges of prescription with Smile. I think minimizing suction loss is a very key aspect of being successful with Smile because of that very soft dock of the VisuMax laser. And so really rehearsing what you're saying preoperatively and intraoperatively to your patient, the concept of verbal anesthesia becomes very paramount for your Smile cases. And I actually practice this quite a bit by performing LASIK flaps first with the femtosecond laser prior to transitioning to Smile. So it allowed me to practice head positioning, centration of my treatments, and even what I was saying throughout the course of those 30 seconds of treatment that helped it feel very comfortable for me when I started doing Smile. I think it's smart to start with higher prescriptions and work your way down, starting with prescriptions of higher than -4 and even including astigmatic treatments helps you create thicker lenticules that are easier to dissect and easier to identify planes in. And ultimately, just like you're learning cataract surgery or any other surgery, you need to learn Smile surgery. So knowing how to identify your anterior and posterior planes and knowing your rescue maneuvers when you identify perhaps posteriorly first, when you aim to dissect anteriorly is important to feel comfortable with. So my patient did very well. He was 20/20 in both eyes. He had well-centered ablations and good myopic flattening as seen in his topography, and was very thankful that we were able to perform Smile for him. And so for our last case, we have a 50-year-old gentleman who came into my office and he was seeking spectacle independence. And he was a strikingly high hyperope with a lot of astigmatism and presbyopia. And because of the range of his refractive error, I didn't feel that excimer laser ablations would be sufficient to help treat his entire refractive error. So we sought to perform a clear lensectomy in both of his eyes. And we chose to use the Eyehance intraocular lens by Johnson & Johnson. And we performed surgery on his left eye first, which was his dominant eye, and aimed it for distance. And then used the toric version in his right eye with a little bit of mini mono, aiming about -0.5 to -0.75 in his non-dominant eye to give him a little bit of depth of field. And I showed it to him in clinic to have him understand what that would feel like, and he was okay with it. He comes back a month later and we're right on the target in the left eye, but we ended up a bit more myopic in the right eye than we had intended. And unfortunately, the patient wasn't too pleased with his monovision. He felt that he couldn't quite focus at any of the distances he needed to do his work or his job or hang out with his kids. And he even felt like his visual field was getting encroached upon with this myopic error. So Dr. Alfonso, I think our refractive patients are oftentimes our most challenging patients. They pay a premium price for a premium result. And sometimes the eye heals differently and we have a refractive surprise. Do you have any pearls on how you manage the unhappy refractive patient?
Well, I think you hit it on the head, Nandini. You got to talk to the patient even after the procedure when they are unhappy, because oftentimes you'll uncover history that the patient may have not really come forth to tell you at the time of the procedure. So that near vision that he is unhappy with may be due to multiple reasons. And one of the most common things in a patient of that age is whether they're beginning to have some difficulty with dryness. And I've seen patients that come in and how they even express their unhappiness with the reading vision has to oftentimes do with some corneal changes due to slower blinking and evaporation. So I would really be careful before offering any further treatments that may be more permanent, to question the patient carefully as to what is it that is happening when they are unhappy with their reading vision. I would say that also oftentimes giving them a little bit of time to adjust, and I know you did that with this patient, gave them enough time, but sometimes I think surgeons are too quick to act and not give the patients the right amount of time. And lastly, what I was going to say is, if you coach the patient postoperatively, I was very impressed with my colleagues in Mendoza, Argentina, that when they were doing a lot of refractive surgery, I was very, very surprised. I was very pleasantly surprised at how much coaching they did of their patients to teach them how to read, how to use lighting when they were reading, and really become adept at using the refractive error that you left them with. If all that fails, then you got to do something. But I'm sure the other speakers can also address the unhappy refractive patient better than I can.
Dr. Garg, Dr. Wiley, any additional thoughts on the unhappy patient?
Yeah, I mean, I'll start. I think you want to try to figure out why this happened. In a short eye, ending up a little bit myopic is not uncommon. We tend to overpower our lenses. So, in patients who have abnormal eyes, this is where I again tell them that, some of our as good as Graham Barrett is, some of our calculations can be off in these patients. So you want to set them up for that possibility, especially if there's a higher risk for that. With this patient, I agree with Dr. Alfonso. I would give them some time. And the other thing that I do with patients when they're unhappy is, if they say, gosh, I can't see distance, what I'll do is I'll negate that and I'll show them what they're going to miss up close. And when you show them that, hey, you know what? Oh, if I give you the distance, if I fix this, you're going to lose what you have up close. All of a sudden now they say, oh, not so bad. And they may take some time. And the other thing that I've been doing more recently that I think was really helpful is really just testing the vision with both eyes open for distance, both eyes open for close, and letting their brain sort of use the binocular summation, naturally and see what they're seeing. Because if they do the one eye salute, certainly they're going to notice a difference and they may be unhappy, but with both eyes open, they may not notice it as much.
Absolutely. That refractive salute is often the most challenging to convince patients to stop doing. You always have to let them know to learn to use both eyes together. But Dr.
Totally
Wiley,
great
thoughts?
Yeah, I think Dr. Garg and Dr. Alfonso covered it well. I totally agree. You have things you can do is like Sam discussed, is maybe a contact lens trial to show what the vision might be like if we were to change it. And so often with that contact lens trial, they say, oh, wow, actually, I kind of like it without the contact lens. And so that can sort of simulate what an enhancement might look like. Sometimes, a YAG laser might allow a shift in the effective lens position. I've seen maybe viscoelastic trap behind the lens and cause a little bit of a myopic shift. And so I might look closely at something like that to make sure there's nothing going on that's causing that, myopic shift. But, these are, the unhappy refractive patient is challenging. And so I think often just listening to them, giving, time, demonstrating, different sort of corrections. I think that's helpful. Often discuss myself as a refractive surgery patient. I tell patients, I'm like, I had refractive surgery 20 years ago. In general, I'm doing great. I do keep a light pair of glasses in my glove box that I drive with. Soon, I'm going to need glasses for reading. I'm sort of in denial for that. But I tell people that refractive surgery is, good for sort of less dependence, but it may not be complete independence. And so I sort of just discuss myself and what I've done, and that it's not a failure of the refractive surgery. It's just sort of nothing's perfect, and we're trying to find what the best outcome or the most functional outcome might be.
I totally agree. I also find that, spending extra time with these patients, almost hand-holding them, is critical. I'll schedule them on an admin day or at a time in clinic when I'm not too bogged down, so that I can sit and I can listen to them and I can acknowledge their concerns, and I can show them that we're trying to come up with a plan that's going to help them, just agreeing with them and saying like, hey, I know you're unhappy. Let's figure out what we can do, to make this better. And this gentleman was never unhappy. He was just very matter of fact. He's like, I just don't like this. and what can we do about it? So time, I think tincture of time is always the best treatment. So we waited, at least 2 to 3 months to see how he felt. I gave him a contact lens trial for about 2 to 4 weeks to see how he acclimated to it. And he loved the contact lens trial, and his vision was very stable with multiple different refractions and data points. Despite, lubrication, repeat imaging, he was coming back with very consistent results. So we started to broach the topic of an enhancement. And Dr. Garg, when you consider enhancements in patients, do you have a preferred technique? Do you prefer PRK over LASIK? Does SMILE have a role, or topography guided ablations?
So I think when you look at enhancements, and it really depends on what the underlying lens is. I was always taught that, when you do an enhancement on any patient with a lens inside their eye, whether that be monofocal, enhanced monofocal, multifocal, trifocal, you really want to do a conventional treatment, because what you're treating is the refraction, and you're not treating your diagnostic that you'll get from whatever diagnostic machine you have. I do agree with Bill here. If you're going to go down that route, I would do a YAG first. Make sure you remove that impediment, whether that's going to be quality of vision or a refractive shift. And then I've done both. I've done LASIK and PRK for these patients. Usually they're low corrections, so that works well. PRK has the longer healing time, and so depending on your patient and what other pathologies they have, sometimes PRK can be therapeutic. So if they have a little ABMD, you may want to do some PRK to treat both at the same time. If they're really, wanting to get their vision back really quickly, and you don't think they'll deal with the longer recovery time, then perhaps LASIK.
Sure. And Dr. Wiley, have you ever done SMILE for any enhancements, or typically LASIK or PRK?
Sure. We have done, a rare SMILE on more of a bioptics approach, maybe a high prescription where we knew the residual is going to be, a -2 or -3, where we've maximized maybe an ICL treatment, and now we have to do an additional corneal procedure or maximize an IOL treatment. But often the enhancements are small, that's, sort of fall below the threshold of what SMILE can treat. So often then we're looking at LASIK versus PRK. It's interesting, Dr. Berdahl and Greenwood just worked on a study out of Sioux Falls, and they did a large analysis of these low prescription post IOL enhancements in elderly population, and PRK versus LASIK, and actually showed that LASIK was preferable for the outcome. That they believe that's a little bit less variability in the healing response, that sometimes removing the epithelium induces a variable that can be hard to predict. So short of, let's say, like Sam discussed, if there's pathology like ABMD or something like that, I think you can be therapeutic for both refraction and the pathology. But if it's relatively normal, I think LASIK might be a little more precise. So I tend to lean for that. Sometimes there is something to be said. Sometimes for a multifocal or a patient that's having issues, by doing PRK, it's almost like a neurological reset or reboot. Their vision gets so poor, and then when it comes back, they kind of maybe appreciate it differently. So we have done it for psychological reasons, not so much punitive, but I suppose it is in some regards. But that's a consideration. So I think there's a lot that goes into the consideration when looking at all these things. So I don't know if there's a right or wrong universally, but you have to kind of consider all those aspects.
I like that, the psychologic input of PRK after a multifocal. Right.
Nandini, I was going to add that since I've known you since you were a resident, and one of your great qualities has always been how you put together teams of people to work with you and do things with you. And I think that sometimes in these refractive patients that need a little bit more help, calling in a colleague and having the patient see a colleague, knowing that your colleague is probably going to reassure the patient that everything is good, and just need to wait a little bit. There's nothing like bringing a prophet from a different land into the patient's thinking process, and I have always found that that is a terrific reassurance to the patient that it's okay to wait and get used to this wonderful vision that I'm going to enjoy.
That is a fantastic point, Dr. Alfonso. I actually often, especially in the beginning when I was starting practice a year ago, would have my senior colleague come in and say hello to the patient, or take a look if there was something I wasn't sure about, or even have the patient see her at times for a second opinion. And, you're pleasantly surprised how appreciative patients are that you've brought in another expert to take a look at their case. They feel very appreciated. They feel that their case is very unique and that they're getting extra care. And I know I feel, even as a patient myself, I would appreciate a second opinion or a second set of eyes to look at myself. So I think that's such great input. The last question I had about enhancements is actually, sometimes after laser vision correction, if patients have had regression, I often find that their topographies are very irregular. Do you ever find the utility for topography guided ablations in those enhancement patients, or do you default more so to wavefront optimized or wavefront guided? Dr. Wiley or Dr. Garg?
Yeah, it's a good consideration. Depending what's going on, I think topography can be considered. But one thing that always worries me is the sort of relative percent of the ablation that's going towards the irregularity versus the main prescription. So if you're treating, let's say, a -5 or -6, maybe 5% or 2% of the prescription is the irregularity versus the main prescription. But if you have a low prescription and over 50% or 60% is attributed to the irregularity, I think there's an increased chance of some kind of missing the target or overcorrection or undercorrection because there's so much of the treatments going towards this irregularity. So if it's real, maybe you prep the patient. It may be a 2-stage procedure where first you're going to sort of debulk some of the irregularity. And if you hit the sphere, great, but you might be prepared that you might have to go back and treat the sphere later.
That's a great point.
Yeah, I'm generally treating retreatments with conventional treatments. I feel that gives me the best chance of getting them happy. I may not, hit 20/20, but I'm just trying to improve their outcome. So, that's sort of the way I approach these patients.
That's great. That's what I've seen for the majority of the patients and what I've been doing as well. But it's helpful to think of the thought process of if, topography guided ablations play a role or not. And so I ultimately decided to do a PRK enhancement for this gentleman, a wavefront optimized treatment. I just saw him last week and he's already 20/25 and thrilled. He feels that all of his symptoms have resolved. He feels that both eyes are working together. He has no concerns about wearing reading glasses when he needs to, and ultimately a very satisfied patient. And so I was very happy that we spent a little bit of time walking him through it, making sure he was happy with that decision, and we ended up with an excellent visual outcome. So just as some key takeaway points from our talk today, I'm just so enthused by how dynamic of a field refractive surgery is. And walking into practice, I didn't know that I would love refractive surgery so much, having done a cornea fellowship, but it has become the most fast growing and most exciting aspect of my practice. And I think what draws me to it specifically is how customizable it is. As one of you mentioned, it's not a one-size-fits-all venture. Really, you have to pick the best procedure for your patient, and each patient is so different in how you have that conversation. And when you hit your target, the results can be incredibly gratifying. It's life-changing for patients, especially in the COVID era, where I have seen an influx of patients who want to be spectacle independent and who want to make that financial investment in helping improve their vision. And I think as a young surgeon, and for all the young surgeons out there, when there are so many different new and advancements and techniques that are available in your field, I think it's important for us to critically evaluate all of the ones that are out there, see which ones we're interested in, and gain the support to start implementing it into our practices. And what is wonderful is that in the next 5 years, our techniques and laser platforms are going to continue to improve with time. So likely what we're doing today will be very different from what we're doing in a few years. And I think it's an ever-changing and ever-learning process in ophthalmology, which is why I was so drawn to the field from the beginning. So thank you so much to my panelists and to all the organizers for allowing me to share my thoughts today. This has been such a great conversation. And if there's any questions, we can address them at this time and continue the conversation.
I have a question for you, Nandini. So are you gonna, now that you've shown us that you're such a superb rising refractive surgery surgeon and ophthalmologist. Are you going to tell us a little bit of how you do the Russia fusion dance?
The Russia fusion dance. How I do some Indian dancing on the side.
Well, that's why we took you into the residency at Bascom Palmer, because you were supposed to be the international dancer, and then someone said, "Oh no, she's a classical violinist," and I said, "Oh my God, so let's double take her."
Oh my gosh. I'm so impressed you remember that from my application.
Yeah, and you can talk to us in Tamil and Sanskrit and maybe a little French.
Oh man!
For those of you guys there, this is a true star. She is really, awesome. She hits it out of the park all the time.
Oh, nice. Thank you so much. You are too sweet.
Amazing presentation.
Congratulations, Nandini, on that. On influencing Eddie's mind so much. It's amazing.
We're going to be doing Indian dance one day.
Yes, one day for sure. It's happening very soon. I can see it. But honestly, this talk has been exceptional in its own way, because a lot of us, a couple of years back, there was this whole move against refractive surgery. But I think, and I think a lot of the conversations nowadays which I hear is so much more positive, and there's so much more positivity around refractive surgery. And I think advances like SMILE, and other things like topographic guided LASIK, they give such a propel towards the field of refractive surgery, especially corneal based. Obviously, there's also another side of refractive surgery, which is lens based, but we'll talk about that some other time. And I think there have been also organizations that have come in together to propel the whole refractive surgery forward. This has been exceptional, and I think latest advances which we are talking about is also such a huge part for us to impart knowledge to the patients as well as our peers and in this field. So thank you very much, Nandini, to bring this forth, and thank you so much, Sam, Bill, and Eduardo. Thank you so much for being here today, and audience, thanks for a lot for patiently listening and taking part in this discussion. We're really humbled by the support that you've shown us over the years. And remember to just a few housekeeping points. Follow us on our social media. We're there on Instagram, Facebook, Twitter, LinkedIn, etc. The whole event, or this whole episode, is available on YouTube. It will be available 48 hours from now. Please do subscribe if you're watching us on YouTube. Please subscribe on that link below. And thank you everybody for being a part of it. Jen, I can't thank you enough to be with me during these events. It's important to have a partner in crime.
Always an honor. Thank you.
Nandini, last but not least, thank you so much for taking center stage and being the rising star that you are. I don't think there's rising word matches with you. I think, as Eduardo says, you've already risen. So
that's right.
Thank you so much, everyone. Really appreciate it.
Congratulations. Thank you. Bye, folks. We will see you.
Thanks, everyone. Great
Nice
presentation.
Job, Nandini.
It was awesome.
Yeah, great job. Nice to see everyone.
Good to see you.
Thank you.
Thanks, Ash.